Hello, my name is Donna Edwards, and today I'm going to be discussing with you disaster planning for substance abuse treatment centers. The rationale and process for planning. Disaster planning can save lives, lessen injury and emotional trauma, protect valuable equipment and property, and prevent or reduce interruptions in treatment. For all these reasons, your behavioral health service program should coordinate with the community before disaster strikes to plan and prepare for a rapid, effective response to disaster. Program staff members also need to document the plans so that they are easy to understand and use in the chaotic minutes and hours after a disaster strikes, when time is critical. Now let's discuss the essential partners in national preparedness. The national preparedness goal is a secure and resilient nation with the capabilities required across the whole community to prevent, protect against, mitigate, respond to, and recover from the threats and hazard that pose the greatest risk. That is from the U.S. Department of Homeland Security. Providers of essential services. Your behavioral health service program has a special obligation to prepare for disasters because it provides essential services. The federal government has identified 15 emergency support function services that are needed to save lives, protect property and the environment, restore essential services and critical infrastructure, and help victims and communities return to normal after disasters. Disaster services that support behavioral health fall under ESF 8, the Public Health and Medical Services of National Response Framework, restoring and improving capabilities and networks to promote the behavioral health and well-being of the whole community are listed as a recovery care capability in the National Disaster Recovery Framework. Take a look at the disaster planning that can help your program continue to provide behavioral health services to existing clients without such planning. Clients in recovery may relapse to substance use, or their psychiatric symptoms may worsen. At the very time, they must cope with the uncertainties, traumas, and losses caused by the disaster. Patients undergoing medically supervised withdrawal of alcohol or drug use are at risk serious medical and psychological complications if the process is interrupted. Patients in residential treatment programs that close suddenly may have no other safe place to go to continue treatment and recovery. Patients who receive medications for mental disorders at your program, example given, anti-anxiety medications or antidepressants, are at risk of serious withdrawal symptoms, example given, seizures and delirium tremors, or discontinuation syndromes if the medications are stopped abruptly. Similarly, patients receiving medication for the treatment of opiate use disorder may develop withdrawal symptoms in their treatments if their treatments are interrupted and would also be at greater risk of relapsing or overdose. At-risk populations, examples given, children, older adults, pregnant women, people with chronic medical conditions, clients with pharmacological dependencies may face unique hardships and challenges if suddenly deprived of your program support. Just as important, disaster planning can prevent your program to serve new clients. In the weeks and months following a disaster, your program may experience a surge in demand for services from individuals needing assessment or treatments from alcohol and relocated individuals previously treated elsewhere. If your program has not been affected by disaster, it may be called to aid other programs. Example given: treating guest clients, sharing supplies and medication, lending staff members, or other community organizations. Example given: sharing resources, reassessing staff. Last, staff members may be asked to provide emergency community-based behavioral health services. Example: crisis counseling or intervention, psychological first aid, assessments, and referrals. We'll take a look at partners in community preparedness. Your behavioral health service program's disaster planning contributes to the overall preparedness of the community. Proper planning helps your program prepare for potential rapid surges of vulnerable populations needing behavioral health services. It will also help your program rapidly transition services to other locations when your resources and community are overwhelmed. A variety of factors or triggers are thought to contribute to higher demand for behavioral health services in disaster, including restricted movement, example given: quarantine, shelter stays, or evacuation. Limited resources, including denial of, limitation of, or suspended access to care. Trauma, both direct and indirect, such as though media exposure. Limited information, including inaccurate information or rumors, or perceived danger. The rationale for disaster planning. Disaster planning isn't just prudent and practical, it is required. Most states require a disaster plan for program licensure. The Joint Commission and CARF International each require a disaster plan for accreditation. Programs offering mental or substance use disorder treatment services must be in full compliance with licensure regulations, including those pertaining to disaster planning, to receive Medicaid reimbursement. Disaster planning is required for opiate treatment program certification. Behavioral health service programs that belong to healthcare coalitions receiving funds through hospital preparedness programs are obligated to plan for responses to common medical disasters and conduct an annual surge test to ensure that they can direct overflow patients and partner facilities. Medicare participating providers and suppliers, federally qualified health centers, rural health clinics, and other primary care safety net providers are required by the Centers for Medicare and Medicaid Services to develop an effective and robust emergency preparedness plan that addresses risk assessment and emergency planning, policies and procedures, a communication plan, and training and testing using an all-hazards approach for disruptive events. Mobilization of behavioral health responders to assist earthquake emergency responders. The steps are taken in Haiti include psychological readiness preparedness for responders before they were deployed and assistance with stress management, addiction risk, and other emotional and behavioral health concerns during deployment. Mental health professionals were embedded in national disaster medical system teams in Haiti, and a mental health officer served in the incident response coordination team. In addition, responders received a symptomatic post-development education that included advance on expected response and danger signs indicative to emotional and behavioral health problems and on how access appropriate follow-up resources should they be needed. Overall, this effort to include mental and behavioral health concerns in the response broke new ground and can serve as a model for the future. Discriminatory attitudes that affected care for people with mental disorders. After a devastating tornado forced some clients of a behavioral health service provider to stay in a shelter, the shelter's rule kept them from receiving attention and treatment there. Even with direct intervention by the provider and the State Department of Mental Health, the provider was denied timely entrance to treat those clients suffering from the complicated effects of the tornado, sheltering, and a lack of medications and services. As a result, clients decompensated and issues occurred at the shelter that could have been prevented. Several individuals were even hospitalized because they went without need of treatment. The behavioral health service provider was invented only after one resident who had been trying to ask for help caused major concerns for the staff and other shelter residents. To compensate for the lack of entry into the shelter, the behavioral health service provider set up on-site rapid psychiatry visits across the shelter. Shelter residents who were current clients could access refills of their prescriptions and in many cases received free samples because their medication had been destroyed. Ultimately, a significant number of clients residing in the shelter took advantage of the service and improved. To prevent future shelter challenges, the local behavioral health service provider, the State Department of Mental Health, and the State Emergency Management Agency worked with the shelter provider jointly, develop a memorandum of understanding, and the behavioral health service providers now maintain a copy of the MOU to show on-site shelter staff. That affect care for people with substance use disorders. Interviews with employees of opiate treatment programs throughout the Gulf Coast rained after Hurricane Katrina and Rita suggest that discriminatory attitudes against people with substance abuse disorders, particularly people who are receiving dispensed methadone, complicated some individuals' ability to access needed services and compassionate care. In one community, evacuees being transported from public shelter to an OTP for daily methadone dosing were required to have an armed police escort on the short bus ride. If officers were busy attending other duties, the patients, as well as the staff members who would dose them, had to wait until the officer became available. In another community, a provider reported that police refused to allow patients access to the methadone clinic located past the food lighted area, despite their having a physician letter stating that they were clinic patients. Networking from social service providers, educating them about SUD treatments, and establishing relationship with them before a disaster occurs may reduce discrimination-related problems for clients during or after only each such incident. Networking to improve readiness. Here's an example. A behavioral health service program reported that it is among the first organization in its community to get power back after outage because it is on the same priority electric grid as a nearby hospital. A drawback to this location is that during an emergency, authorities secure the area surrounding the hospital for emergency vehicles only. The OTP administrator worked with the county government officials to have OTP staff members designate as emergency responders so that they could receive emergency responder IDs. These staff members now have ready access to clinic when they encounter a roadblock, but challenges remain for patients trying to get the program. After one hurricane, law enforcement officials set up a roadblock at a nearby intersection where an officer demanded that the patients show proof that they were patients of the methadone program before permitting them inside the area. The administrator went to the roadblock with her patient list in hand and confirmed identities for police. If I didn't know the patients, if they were not a name on the list, she reported, they didn't get in. To avoid problems of this nature, ask law enforcement or authorities about the circumstances under which access to your facility may be restricted and negotiated in advance with an access plan for staff and patients. Here's another example why networking to improve readiness for a disaster is important. A behavioral health service program faced problems when its community emergency evacuation traffic measures. In an evacuation, the highway became a one-way through far heading out of town. Once a vehicle enters the highway, it cannot exit the local streets. This presents a risk that clients and staff who are delayed at the clinic to complete dispensing of take-home medications when the emergency traffic pattern is implemented won't be able to return home to prepare for the community's evacuation. To avoid problems of this nature, ask local authorities for information about possible disaster traffic control measures and road closures, and ask community traffic planners for guidance on routes around potential roadblocks. However, program disaster planners should keep in mind that in an actual disaster, alternative routes might not be available, and detours can greatly increase travel time, especially if power outages turn intersections with traffic lights into a four-way stops. There is an importance of coordinating and testing plans with others. The Joint Commission has expanded the requirement for disaster planning to include testing the plan in conjunction with other community partners. One example of the importance of testing with partners involves the Behavioral Health Service Program focused on providing treatment across 3 counties. The program diligently conducted early planning and training for each site, and program staff expressed confidence in implementing those plans. Early planning included written agreements for sheltering with the local schools and daycare facilities and priority transportation by the private ambulance company. Testing the plan and conducting simulations within the program went very well. However, when each state reached out to their collaborative partners to conduct joint exercises, flaws became apparent. The Behavioral Health Service Program found out that the local school had contracted with the skilled nursing facility for the same space. The ambulance company was found to have decreased its numbers of RIDs, making it impossible to accommodate all patients in a safe manner. The Behavioral Health Service Program went back to the planning stage, reevaluating next steps to correct and improve its plan. The program reached out to additional partners to address sheltering and transportation during and after disaster. Program staff also included specific instructions on acting and deactivating their plan at each program site. Here we have the behavioral health, a pivotal partner in healthcare coalitions. Missouri was an early adopter of healthcare coalitions as required by the U.S. Department of Health and Human Services. ASPR, and maintains 3 robust, inclusive healthcare coalitions covering the entire area and population of the state. Each healthcare coalition has membership from 4 core groups: hospitals, emergency medical services, public health, and emergency management. Behavioral health service partners, while not required by ASPR, are embraced by Missouri's Healthcare Coalition as necessary to emergency planning, mitigation responses, and recovery efforts. Missouri has used funding from both the CDC Public Health Emergency Preparedness Program and ASPR to build our behavioral health strike teams and respond to emergencies in our state, including mass fatality incidents, tornadoes, and other severe weather events, civil unrest, and infectious disease outbreaks. In addition to the Missouri Department of Health and Senior Services hosts a biannual meeting and healthcare coalition leaders known as the Leadership Partnership. Missouri's behavioral health service providers have provided invaluable insight into the behavioral health aspects of disaster response and helped healthcare partners statewide recognize and respond to our citizens' behavioral health needs. In addition to being involved at the leadership level, behavioral health service providers in Missouri are active in their regional healthcare coalitions, joining public safety and public health partners in common cause of making communities safer, healthier, and more resilient. Collaborative planning by healthcare organizations. The Northeast Healthcare Response Network. Together, more than 3,000 healthcare organizations and 178,000 healthcare workers representing hospitals, behavioral health service providers, ambulatory care organizations, first responders, in-health service, public health departments, blood dialysis and lab services, emergency management departments, long-term care providers, tribal nations. The network provides a critical link among healthcare facilities, public health departments, and other key government partners. It does so by developing and maintaining a comprehensive system that helps ensure coordination, effective communication, and optimal use of available health resources in response to emergencies and disasters for all hazards. The network in the Western Washington Administration of Washington System for Tracking Resources, Alerts, and Communication, Washington State's web-based healthcare resource tracking and alert system for statewide collaboration on a daily basis and during emergency response. The information about WattTrack is available at www.dohwagov/FOR public health care provider / emergency preparedness / WATRAC. The network facilitates region-wide planning with healthcare and other emergency response organizations to establish relationships, leverage enterprise, and develop plans and tools. The network maintains 6 committees: an acute infectious disease advisory group, a long-term care response team, training and exercise advisory work group, Western Washington WattTrack Advisory Committee, Disaster Clinical Advisory Committee, and the State Supply Chain Resiliency Work Group. Before disaster strikes, the network operates behind the scenes, preparing and training healthcare providers in innovative emergency response and recovery practices. During an emergency, it functions as the eyes and ears of the healthcare community, providing critical situational awareness, patient tracking, resource sharing, and coordination, and collaborative response and policy. Disaster constructive messages for individuals and communities. Understand the individual effects of a disaster. It is normal to feel anxious about your own safety and that your family and close friends are okay. Profound sadness, grief, and anger are normal reactions to an abnormal event. Acknowledging your feelings helps you recover. Focusing on your strengths and abilities help you heal. Accepting help from community programs and resources is healthy. Everyone has different needs and different ways of coping. Anger and grief may show up as trembling or shaking, muscle weakness, nausea and trouble eating, trouble sleeping and difficulty breathing, dry mouth, nightmares, social withdrawal, lack of interest, and unusual activities. Adults have the following signs. They might need crisis counseling or stress management assistance. Difficulty communicating thoughts, difficulty sleeping, difficulty maintaining balance in their lives, low frustration tolerance, increased use of drugs or alcohol, limited attention span or difficulty concentrating, poor work performance, headache or stomach problems. Also, tunnel vision, muffled hearing, disorientation or confusion, reluctant to leave home, depression, sadness or feeling of helplessness, mood swings and bouts of crying, overwhelming guilt and self-doubt, fear of crowds, strangers, or being alone. The following are ways to ease disaster-related stress. Talk with someone about your feelings, even though it might be difficult. Seek help from a professional counselor who deal with post-disaster stress. Do not hold yourself responsible for the disastrous event or be frustrated because you feel you cannot help directly in rescue work. Take steps to promote your own physical and emotional healing by eating healthy, resting, exercising, relaxing, and meditating. Maintain a normal family and daily routine while trying to limit demanding responsibilities on yourself and your family. Spend time with supportive family members, friends, or spiritual groups. Participate in memorials. Let's take a look at the components in the community thorough. The first step is the identity to identify the threats and hazards of concern. List of threats, hazards. The second step is give threats and hazards context. Context the description for threats and the hazards. The third step is to establish capability targets. And then the fourth step is to apply the results, which include the resource requirements. Of giving out welcome bags and personal go kits. Our team has created welcome bags for our residential intake clientele that contain toiletries as well as comfort items such as blanket, a journal, a deck of cards, and a novel or book of meditation. We also put clothing, sweatsuits, and t-shirts sized at admission into the welcome bags of patients who are emergency intakes and have not had time to prepare for admission. We prepare 20 to 30 welcome bags at a time that we always have an adequate inventory and try to have 10 for each gender on hand at all times. The welcome bags are backpacks with design ID tags and space for storage of medication. It should also need a rise for evacuation. We also store about 40 similar emergency go kits in the same location. These contain water, high energy food bars, and other foods with shelf life, such as dehydrated fruits, and the to-go kits are stored near the welcome bags to be placed in the backpacks or provided to staff as needed. It's a really good idea for your facility. For a power failure, at an inpatient behavioral health service program in the state of Washington had a court-ordered individuals among its patients to allow someone to exit through the facility doors. A code had been entered into the electronic keypad. When the power failed, the doors automatically unlocked, and to the surprise of the program's administrators, some of the court-ordered patients nearly escaped. Although the facility had a generator, the electronic keypads were not connected to it. After this incident, the facility's staff connected the electronic door system to the generator and instituted a policy of regular testing. Disaster mitigation specific to behavioral health service program. Store medication in a safe, locked area that can be protected from most likely hazards. For example, programs in food-prone areas can store medication above ground level. Programs in earthquake-prone areas can store medication in cabinets secured to an interior wall. Maintain a 3-day supply of water, food, linens, garbage bags, and sanitation products and other provisions to sustain the maximum number of people. Example given: clients, staff members, volunteers, visitors who may be on your premises at any one time. The supply should include provisions needed by people who may be on the premises and who are defined at risk. Example given: children, senior citizens, pregnant women, those with chronic medical disorders, those with pharmacological dependencies, as well as provisions for any pets or service animals on the premises. Keep an inventory of these supplies and check the expiration date as necessary to ensure their safety and effectiveness. Keep coolers on site for use when transferring refrigerated medications to another site. Ensure electricity-dependent systems such as security alarms and water pumps have battery backup or are connected to generators that will start when the power is lost. Ensure that all means of exit from building will be accessible if the power is lost. Example given: test emergency lighting in the hallway, stairwells, and exits to ensure it works properly. Mutual aid following a major snowfall. In 2009, the state of Washington experienced an unexpected heavy snowfall. More than 5 feet of snow fell within a month in some areas. As temperature rose, the snow melted. Food risk increased. An OTP administrator became concerned that her facility might have to close temporarily. She contacted an OTP in negotiating King County to arrange for guest dosing of her program's methadone patients. This neighboring OTP was party to a mutual aid agreement agreed under the Auspices of Healthcare Coalition that described the terms under which King County's OTP would provide guest dosing services to one another. The King County OTP used the mutual aid agreement as a template for a new agreement between itself and the OTP located outside King County that was a risk of flooding. Fortunately, the patient transfer was not needed, and the two OTPs now have an agreement in place for future use. Issues to consider in mutual aid agreements. Agreements to provide mutual aid for staffing assistance may be helpful, but the ramifications such as efforts are best explored in detail long before any disaster occurs. An administrator at a program that experienced an influx of displaced clients after Hurricane Katrina felt that having more staff members would not have helped. He explained, "We have a limited of space, and we knew what we would have to be done. If you weren't already working here and didn't know what needed to be done, you would have been trained, and we didn't have time to train. An administrator at another program affected by the hurricane was part of the network of the clinics and requested staff assistance from an affiliate. The greatest challenge, he reported, was finding housing for the guest workers. 3 people stayed with the administrator and his family at a small home, and the others stayed with another staff member. We put them in our own houses and fed them and brought them to work with us in a very difficult time. Similar challenge occurred at other programs. One provider, for more than a month, housed several medical volunteers in a motorhome parked outside of his house. This is the incident command system. Here is a hypothetical example of an ICS in action. Here are some financial aid opportunities after disasters. The federal government, foundations, and some organizations have made grant funds available to help jurisdictions and organizations rebuild after disasters and to support them in preparing for future emergencies. Many of these opportunities listed below have eligibility requirements based on agency affiliation and disaster need. Psychological first aid. Promote safety. Help people obtain emergency medical attention. Help people meet basic needs for food and shelter. Provide repeated, simple, and accurate information on how to meet these basic needs. Promote calm. Listen to people who wish to share their stories and emotions. Remember that there is no right or wrong way to feel. Be friendly and compassionate even if people are being difficult. Offer accurate information about the disaster or trauma and the relief efforts underway to help victims understand the situation. Promote connectedness. Help people contact friends and loved ones. Keep families together. Keep children with parents and other close relatives whenever possible. Promote self-efficacy. Give practical suggestions that steer people toward helping themselves. Engage people in meeting their own needs. Promote help. Find out the types and locations of services and direct people to those who are available. When people express fear or worry, remind them if you know that more help and services are on the way. Do not force people to share their stories with you, especially very personal details. Give simple reassurances like everything is going to be okay or at least you survived. Tell people what you think they should be feeling or thinking or how they should have acted earlier. Do not tell people why you think they have suffered by alluding to their personal behaviors or beliefs. Working with regional partners after a disaster. Over the years, many partner organizations have been helping one another following a disaster. One example involves a mental health service provider that lost more than half of its facilities in a tornado. Several destroyed facilities provided housing to individuals with serious mental illnesses. These residents needed immediate referral and transportation to another facility. A partner organization located in the same region was finishing work on a new residential facility and offered the site as an option. Residents were quickly transferred to the empty new site until more permanent arrangements could have been made. In another example, a behavioral health service provider was overwhelmed with volunteer calls while trying to reach and assign staff, locate clients, and find alternative treatment sites following a disaster. A partner organization created a virtual human resource site that allowed all volunteers to be directed to one website where activities were being coordinated. The site required volunteers to complete an application and upload resumes, licensures, and other credentialing information, and critical details used for verifying credentials and conducting background screenings. The partner organization managed the site for 6 weeks, ensuring the community had access to volunteers who were highly qualified and credentialed with appropriate experience. It organized, scheduled, and transported the selected volunteers. This support allowed the behavioral health service provider to organize staff, locate alternative facilities, find existing clients, and begin to plan a community response. Here are some examples of essentials and non-essential functions. The program type with all of the programs. Essential functions include provide for the physical safety for all clients and visitors at your facility, provide crisis stabilization, crisis intervention, and other emergency services to clients and the community, conduct basic screening, intake, treatment, and discharge procedures, track clients affected by dispersal and evacuation to ensure that they continue to receive needed behavioral health services, provide behavioral health services at shelters and temporary housing sites, assist clients with accessing and replacing needed medication, conduct drug testing for mandated clients as required, check with relevant authorities on whether requirements have changed because of a disaster, adhere to applicable state licensing standards, maintain treatment and billing records in accordance with payer and regulatory requirements. Document transfer of clients and their records to another provider. Protect clients' rights and privacy, which include ensuring the integrity of the protected health information records. Provide disaster, mental, and substance use disorder services to the community as requested by the Emergency Operations Center or emergency support functions. Provide prevention guidance specific to the present disaster to reduce the likelihood of traumatic stress in your programs, clientele, and other members of the community. Identify staff members to work at the Multi-Agency Resource Center. If one is established, a MARC brings together multiple service providers in a single location to deliver services to people affected by a disaster. Evaluate funding opportunities, including those that arise as a result of a disaster. Example given, grants issued by the U.S. Department of Health and Human Services, HHS, and to address the COVID-19 pandemic. Here are the examples of essential and non-essential functions. Check availability of alternate treatment sites. Alternate sites identified as part of a disaster planning may become unavailable in an actual disaster, so this can be an ongoing process. Staff the first responders debriefing team. Identify staff members available to provide services. These non-essential functions include performing extended intake and discharge procedures, conduct non-mandated drug testing, offer routine counseling and education, provide psychological testing, provide routine lab tests, provide non-disaster related educational awareness activities, provide non-emergency transportation. If residential facility is not safe, provide alternative residential treatment options, deliver a psychosocial rehabilitation services. For the outpatient treatment programs, the essential functions include assist with case management activities such as linking to resources, including helping clients obtain medication replacements or refills as appropriate, secure support from other providers to meet the needs of clients whose medications were destroyed, provide crisis stabilization, crisis intervention, or other emergency services to outpatients. The non-essential functions for the outpatient treatment programs are providing regular outpatient services, host on-site mutual health group meetings, donate meeting space for community groups. Essential functions for residential treatment programs include providing residential care for patients who do not meet discharge criteria, stabilize patients undergoing non-medical detoxification, continue medications and supportive counseling to patients to prevent decompensation or escalation of symptoms of mental or substance use disorders, or both. Coordinate or address transportation needs for accessing medical services. Provide case management services as appropriate to move patients toward discharge readiness. Transfer clients to area residential providers if your program's facility is unusable or destroyed. Non-essential functions for residential treatment programs. Provide residential care for patients who can be discharged. Here are some examples of essential and non-essential functions continued for medically supervised withdrawal programs. Follow established medically supervised withdrawal protocols. Medically stabilize patients. Closely monitor patients' withdrawal symptoms. Transfer patients who require a higher level of medical care than your program can provide to an appropriate facility. Provide residential care for patients who remain at the facility. Confirm that essential supplies and services are available. Here is a non-essential function for the medically supervised withdrawal programs. Medically detoxify patients who cannot be safely transferred to and detoxified in another setting. Right, essential functions for the opiate treatment program, the OTPs. Confirm identities and dose information for patients receiving medication. Provide or facilitate access to prescribed or dispensed medication. Examples given: methadone, buprenorphine. Staff members must at all times include a provider who is waivered by the Drug Enforcement Administration, the DEA, to write prescriptions for buprenorphine, also known as having an X waiver. Provide case management to assist with medically appropriate transfer or discharge. Here are some non-essential functions for the OTPs. Provide other case management service beyond those determined essential. So, continuity of essential operations during a winter storm. A major winter storm, standard residential program staff members in their homes and resulted in an on-duty staff members extending their shifts to nearly 72 hours. Travel was not advised and access to the interstate highway was closed. Food was not an issue because the program had stored a 2-week supply of provisions. The program had recently purchased and implemented a web-based client management system that clinical supervisory staff could access from home to create and modify treatment plans that could be implemented by clinical staff. This system allows staff to document client progress and medical updates with no interruption to the client's services. During the storm, individual therapy sessions had been rescheduled or canceled because some therapists could not get to work. The on-site team had to be creative given the limited number of staff, so the program assumed a comfortable retreat atmosphere as the staff took the opportunity to work with the clients more deeply on group topics as opposed to individualized sessions. It was decided afterward to plan a series of mini retreat activities as of the shelf. Options for use of furniture incidents when the program is short-staffed because of the emergency. Getting help with essential operations during a pandemic. The Missouri Coalition for Community Behavioral Health Representatives, Missouri's not-for-profit community mental health centers, addiction treatment agencies, and affiliated community psychiatric rehabilitation services providers. Our mission is to enable access to qualified mental health services while maximizing the potential and quality of life through a statewide network of providers. During the first week of COVID-19 pandemic, we learned that our members were in desperate need of personal protective equipment, PPE. Missouri Community Mental Health Centers were dedicated to ensuring safe treatment was readily available to those who depend on them, but employee safety was paramount to keeping service lines open during the pandemic. Our providers quickly found themselves competing in a large medical market without established vendor relationships. Our staff organized quickly and contacted vendors that could deliver large bulk of orders. We used funding from canceled in-person conferences, trainings, and regular meetings at the state, purchasing significant quantities of PPE for our members. We ordered shipping boxes, set up shipping accounts. State started assembly the package in a large conference room and began delivering PPE to all 33 member organizations. As of August 2020, we have delivered more than 275,000 disposable masks, 200 touchless thermometers, and 25,000 gloves, 9,000 bottles of hand sanitizer, and 1,000 face shields. We fulfilled our mission of enabling access to Missouri's mental health system in a way we never imagined. Setting up a communication tree. The coordinator begins distributing a message by contacting the people on the branches directly below him or to her. Those people then contacted below them on the branch. The final people to receive the message contacted the coordinator, completing the chain and confirming that everyone has been informed. If staff members cannot reach an assigned contact, they move to the next person down the branch, passing along the name or names of those who could not be reached. This information is passed along until it reaches the coordinator. Priority communications in an emergency. Government Emergency Telecommunications Services, GETS, is a program of the U.S. Department of Homeland Security Office of Emergency Communications that prioritizes calls over landline networks. Users receive an access card, GETS card, which has both the universal GETS access number and a personal identification number. To get priority access to the cellular communication networks, you need to use the Wireless Priority Services program, WPS, described here below. GETS and WPS can be used in combination. This service is most useful during an event when telephone systems are not damaged, but the circuits are overloaded. In this situation, the caller usually hears a very fast and very slow busy signal after the number has been dialed, indicating that too many people are making calls at the same time. By using the GETS card, subscribers have priority access to the circuit, which allows their calls to go through. Applying for and obtaining a GETS card is free of charge and up to 10 cents a minute at the time of the publication, and applied calls made through GETS. Here's more information on where you could receive that. The Wireless Priority Service, the WPS, is a federal program that authorizes cellular communication services providers to prioritize calls over wireless networks. Participating in the WPS program is voluntary and requires an application. Authorized user dials star 272 on a WPS-enabled device to receive calling queue priority. This service is most useful in situations when the cellular infrastructure is intact, but the circuits are overloaded by a large number of callers. In these situations, the caller usually receives a message indicating that the call cannot be completed or receives a fast busy signal. WPS calls do not preempt calls in progress but provide priority access over cellular communication networks. A small one-time activation fee and small monthly fee does apply, and as does a per minute charge of 75 cents at the time of the publication. For more information, here's where you can apply. Is in effect at all times. The programs are not contingent on a disaster or emergency situation taking place. Storage. The cloud computing platforms provide a scalable, on-demand access to IT services. The cloud can allow you to rapidly launch an EHR system while minimizing management effort and cost. However, it is important to thoroughly understand the benefits and challenges associated with a cloud-based EHR system. Common benefits: reduces upfront hardware and software cost, reduces ongoing maintenance cost, lets you start small and increases IT allocations as needed, provides higher levels of IT services availability than in-house IT services, and reduces runtime failures. Common challenges: it makes the data security a shared responsibility between your program and your cloud clinician. It also offers a lower level of data access and control than an on-site EHR system. In emergency situations, even without a waiver, the HIPAA privacy rule always allows patient information to be shared for the following purposes and under the following conditions. Treatments under the privacy rule covered entities may disclose without a patient's authorization protected health information about the patient as necessary to treat the patient or to treat a different patient. Treatment includes the coordination of management of health care and related services by one or more healthcare providers and others, consultation between providers, and the referral of patients for treatment. See 45 CRF 64502. All right, and the definition of treatment. Public health activities. The HIPAA privacy rule recognizes the legitimate need for public health authorities and others responsible for ensuring public health and safety to have access to protected health information that is necessary to carry out their public health mission. Therefore, the privacy rule permits covered entities to disclose needed protected health information without individual authorization. Health authorities such as the Centers for Disease Control and Prevention, the CDC, or a state or local health department that is authorized by the law to collect or receive such information for the purpose of preventing or controlling disease, injury, or disability. This would include, for example, the reporting of disease or injury, reporting vital events such as births or deaths, and conducting public health surveillance, investigations, or interventions. A public health authority is an agency or authority of the United States government, a state or a territory, or a public subdivision of the state or territory, or Indian tribe that is responsible for public health matters as a part of its official mandate, as well as a person or entity acting under a grant of authority from or under the contract with a public health agency. For example, a covered entity may disclose to the CDC protected health information on an ongoing basis as needed to report all prior or prospective cases of patients exposed to or suspected or confirmed to have COVID-19. Of a public health authority to a foreign government agency that is acting in collaboration with the public health authority. The HIPAA, privacy and disclosure in emergency situations. The person at risk of contacting or spreading a disease or condition if other law, such as state law, authorize the covered entity to notify such persons as necessary to prevent or control the spread of the disease or otherwise to carry out public health interventions or investigations. Disclosure to family, friends, or others involved in the individual's care and for notification. A covered entity may share protected health information with the patient's family members, relatives, friends, or other persons identified by the patient as involved in the patient's care. A covered entity also may share information about a patient as necessary to identify, locate, and notify family members, guardians, or anyone else responsible for the patient's care of the patient's location, general condition, or death. This may include, where necessary, to notify family members and others, the police, the press, or the public at large. Should get verbal permission from individuals or otherwise be able to reasonably infer that the patient does not object when possible if the individual is incapacitated or not available. Covered entities may share information for these purposes if, in their professional judgment, doing so is in the patient's best interest. For patients who are unconscious or incapacitated, a healthcare provider may share relevant information about the patient with family, friends, or others involved in the patient's care or payment for care. If the healthcare provider determines based on professional judgment that doing so is in the best interest of the patient, for example, a provider may determine that it is in the best interest of an elderly patient to share relevant information with the patient's adult child, but generally cannot share unrelated information about the patient's medical history without permission. Entity may share protected health information with disaster relief organizations that, like the American Red Cross, are authorized by law or by their charters to assist in disaster relief efforts for the purpose of coordinating the notification of family members or other persons involved in the patient's care of the patient's location, general condition, or death. It is necessary to obtain a patient's permission to share the information in this situation if doing so would interfere with the organization's ability to respond to the emergency. Or lessen a serious or imminent threat. Healthcare providers may share patient information with anyone as necessary to prevent or lessen a serious or imminent threat to the health and safety of a person or the public, consistent with applicable laws, such as state statutes, regulation, or case law, and the provider's standards of ethical conduct. Thus, providers may disclose a patient's health information to anyone who is in the position to prevent or lessen the serious of imminent threat, including family, friends, caregivers, and law enforcement. Without a patient's permission, HIPAA expressly differs to the professional judgment of health professional in making determinations about the nature and severity of the threat to health and safety. Regarding the patient information in an emergency situation, covered entities must continue to implement reasonable safeguards to protect patient information against intentional or unintentional impermissible uses of disclosure. Further, covered entities, as their business associates, must apply the administrative, physical, and technical safeguards of the HIPAA security rule to electronic protected health information. We'll be discussing management of prescription of medications. helpful worksheets for your behavioral health treatment center to use. At the end of this slide, I will be providing you a checklist for the written disaster plan, a checklist for disaster planning, checklist of state and community representatives and groups, checklist of disaster planning discussion topics, sheltering in place checklist, incident command systems positions, requirements for alternate facility arrangements by disaster scenario, a checklist for relocation planning, identifying essential functions and staff positions, essential staff roster, checklist for continuity planning, checklist for maintaining communications with essential groups, checklist of records and database to ensure interoperable communications, checklist for protecting records and database, checklist for managing human capital, checklist for management of prescribed medication, and a checklist plan for training and testing log.